But don't do it because you want to see whether the bone is involved or not. You want to see whether the lymph nodes are involved. That's okay. Now, where will you take the biopsy from? You said you'll take the biopsy from the edge?
Yes, sir, edge.
What about the other postgraduates? What do you think? Do you need to take a biopsy from the edge?
So preferably from the center of the lesion, because if we take from the edge, the patient will complain of pain, and we can get the most representative part from the core of the lesion.
Yes. You heard that, Sandeep? This is an office procedure, and you don't want the patient to jump in the office. I want to ask you one more question. If the biopsy says this is a hyperplastic lesion, a verrucous lesion, and they are not able to give a Now, the field that it is showing looks that there may be an infiltrative component. But even if you have a entirely verrucous carcinoma growth,
Yes, sir.
the pathologist is not able to give a confirmed diagnosis, or whether it is just verrucous hyperplasia or whether it is verrucous carcinoma.
Yes, sir.
But we have to go ahead and excise it. We can't go on and on and on taking repeated biopsies.
Okay, yes, sir.
You can do it twice, maybe 3 times.
Yes, sir.
But as soon as you feel that now I've taken representative and every time this is the report that is coming from a reputed pathologist, then you have to plan and excise it.
Yes, sir.
And then you can do frozen section. On the full specimen, they will be able to tell you.
Yes, sir.
So what was the biopsy in this case?
It was a fresh case, sir. Biopsy was not done.
Okay. So given hypothetical situation.
So if it is reported as verrucous carcinoma, then what will you do?
Will only access the lesion, sir, by wide excision, and I will not do the next, sir. And I will reconstruct it.
What reconstruction do you have in mind?
As it is involving the commissure and lateral aspects of the lips, both upper and both lower lips, I would preferably take a local Estlander flap, sir.
You said it's a T3 lesion. You think you can do with the Estlander flap? What will be the disadvantage of the Estlander flap in this case?
The competence, sir, oral commissure competence.
A slender flap may not be possible after you excise it, but or any other flap, apart from a slender.
Radial free form flap, sir. Free flap.
Any local flap? Any local flap?
Any-
You might have seen the nasolabial flap, which we are doing so often.
Sir, nasolabial flap also can be done, sir.
So this lesion is too big for a slender flap.
Sir.
Nasolabial may be possible.
Or it may not be possible also.
Or it may not be possible. One limitation of nasolabial flap is that it will go in one direction only. It will not go in two directions. So if you have an upper lip and a lower lip defect, then it's a problem. And you have the radial artery forearm flap. But whatever flap you use for this patient, what will be the end result on the competence of the mouth?
Mostly these will not help for the competence of the mouth, sir.
We'll tell them a little bit about the reconstruction in these kind of.
It's good enough for the basic. These three are good enough.
Anushka, you want to say? Yes? Somebody wants to comment on the reconstruction of this defect?
So free radial forearm flap would be a good option in this case because we'll be excising the entire oral commissure and more than 1/3 of the upper lip and the lower lip as well.
Yeah,
So that will be a better option.
that is the best option. There's no doubt about it.
Yes, sir.
Do you know what we used to repair this before the advent of the free microvascular flaps? What were these defects repaired with?
No, sir.
You heard about the forehead flap?
Yes, sir.
Yeah. So this was very commonly repaired with the forehead flap in the good old days.
Okay, sir.
Right up to the end of the 70s, even early 80s, it was still repaired with the forehead flap. Now, if the report comes as not verrucous, but it comes as an invasive squamous cancer, then what will you do, Sandeep?
Then I will do a wide excision, sir, about 1 centimeter wide excision with all around, and I will do a neck dissection, sir. A comprehensive neck dissection, most probably modified radical neck dissection, sir.
Yes. And post-op, any adjuvant treatment?
Sir, depending upon the histopath report, I will sit for the adjuvant
So
treatment.
the final histopath shows it is N0.
If it is N0, that depending upon the depth of infiltration and perinuclear invasion, and if the depth of infiltration is more than 0.5 mm or LVA or PNI is present, then I will go for the post-op radiotherapy, sir.
But based on this primary itself, will you not radiate?
Yes, sir. As it is T3, more than 4 centimeter, I will definitely plan to radiate, sir.
You said it is 5 by 4 centimeters. You can see that it's a large lesion.
Yes, sir.
And if it is an invasive squamous cancer, then regardless of whether it is N0 or N+, you have to give him radiation therapy. You agree?
Yes, sir.
I want want you to be clear about this. In the exam, you have to be clear about this.
Yes, sir.
If the lymph node is involved, then what will you do? Will you give only radiation or will you give more than that?
Give radiation only, sir. If it is more than 2 lymph nodes, up to 2 lymph nodes, if extranuclear extension is present, or if the more than 3 lymph nodes are present, then we will give concurrent chemoradiotherapy, sir.
So there the count doesn't come in. Anushka, why don't you tell him how you will do what you'll do for the adjuvant treatment?
Sir, if it's a stage 3-4 disease, more than 2 nodes, extracapsular spread seen on histology, positive margins on histology, then we will go ahead with post-op radiation, sir. And since pre-op in this case, it's already a T3 stage 3 disease, I'd like to go ahead with post-op radiation in this case.
Yes, but I'm asking you now, radiation is a must. If this is a squamous cancer, if it's an invasive squamous cancer, radiation is a must.
Yes, sir.
But if the neck is N plus 1 node, what will you do? What will you do?
Sir, no addition.
Only radiation.
Yes, sir.
If it is 1 node with perinodal disease,
then I'll go ahead with chemo also, sir.
yes.
It's a extracapsular spread, then chemo radiation is indicated, sir.
Well, so that this much answer I have to extract it out of you. That shouldn't happen.
Sorry, sir.
It is not a matter of 1 node or 2 nodes or 3 nodes. Please remember that. If this lesion is N0, the treatment is radiation therapy, post-operative, after excision. If it is N plus, but a single node, or 2 nodes, or even 3 nodes, but no perinodal disease, it is still radiation therapy. But if it is perinodal disease, even in 1 node, then the standard is adjuvant chemoradiation. Do you agree with that?
Yes, sir.
Yes, sir.
Kannan, you agree?
Absolutely. I think that's the right thing.
So I think you have to be clear in the exam, you have to be clear about this.
Yes, sir.
All right? In practice, very often when there are multiple nodes, we may give chemoradiation. But as far as we are concerned for our exam, the standard of care is, if there is no perinodal disease, then withhold radiation therapy. Then withhold chemotherapy. Treat with only chemotherapy. What is the other situation where you will also want to add chemotherapy to the adjuvant radiation therapy? What is the other indication?
So positive margins.
Positive margins. Okay, Sandeep,
Yes, sir.
you understood this?
Yes, sir.
Next time, this is the standard answer.
Yes, sir.
Okay?
Yes, sir.
Shall we go to the next case?
Yeah.
Shall we go to the next case? Is there any other question anybody wants to ask? Anushka, you want to ask, or any of our other colleagues, Sanjeev Kumar and Aarti and Irene and Cherry and Sarika and Trishna? I don't hear from them at all.
So in this case, we won't do CT per se. Then, if like you said, we don't have to assess the bony involvement here.
In my book, there is no need for a CT scan for this man. We do ultrasound of the neck. But if you want to do a CT scan and you say it, then you say that it, don't say that it is for assessment of this disease.
Okay, sir.
Assessment of this primary. It is for assessment of the lymph nodes. We here do more of ultrasound because we have a very good sonologist and because ultrasound is cheaper. But
Okay,
you can opt for CT scan, that's okay. but that is for the lymph nodes. You can also say to rule out any other primary that the scan may detect. Sometimes clinically you have missed something, but the CT may report something at another site within the head and neck. That's okay. But for this kind of a lesion, which is miles away from the upper as well as the lower gingiva, you don't say that you want to assess the bone involvement. And
Okay.
also don't say that you want to assess the depth of involvement. You can feel it, it is right there between your finger and the thumb.
Yes, sir. Thank you,
Okay?
sir. Yes, sir.
Thank you. If there's no other question, we'll go to the next case, please.
Thank you, sir.
I would like the postgraduates to participate more, please. Please ask questions. If you ask a question, many other colleagues of yours will benefit.
Sir, I had a question. If this case was N0, do we do a selective or do we do a modified neck dissection?
That's a good question. If it was N0 and you find that the lesion it doesn't look very vicious, it's just a large lesion. Most of the components of this lesion are just verrucous. In some
Yes.
area it is an infiltrative lesion. Then
Yes.
you're perfectly justified in doing a selective
Supraomoid.
supraomoid neck dissection.
Yes, sir. Okay, sir.
So levels 1, 2, and 3 are
Three.
covered.
Yes, sir.
You must be very careful to see that the level 1A is also cleared.
Cleared.
Should be cleared.
Yes, sir. Thank you, sir.
Good question.
But ideally, for that, you have to have frozen section. It's ideal to have frozen section.
Yes. What sir is saying that you have to have frozen section and a good frozen section. One of the objections that people have to a supraomoid neck dissection is if it comes positive, if it is reported negative on frozen section and is reported positive later on the final histopathology, then there's always a dilemma. Should I go in and do a completion neck dissection? Most of us will then not go in for a completion neck dissection because we are going to give radiation therapy
Radiation to the patient.
to this patient.
But sir, a lot of people say that when you're removing levels 1, 2, 3, might as well remove level 4 and be safe.
Yes,
What do you
so
think?
that's an extended supraomoid.
Yes, sir.
You
So
raise
should
your- you raise
extended
your-
supraomoid be done in all cases because we're already removing till level 3. We might as well remove level 4 along in the same surgery.
Yeah, you can do that. You can
Okay.
do that. You just raise your lower flap well,
Yes, sir.
identify the omohyoid muscle and go below that and clear. If you have a good assistant who will retract the lower flap well, you
Yes,
can
sir.
go right down up to level 4 and bring it up.
Yes, sir.
It's a good idea. That's still a selective neck dissection.
Yes, sir.
Good. See, Anushka, your one question benefited so many other people.
Yes, sir.
And I think you knew the answer and yet you asked. Thank you. Thank you. Yes, Ankur.
Yes, sir. Good evening, sir.
Good evening. Now loud, Ankur, loud.
Yes, sir. So, the 55-year-old gentleman, resident of Kolkata, shopkeeper by occupation, presented in our OPD with chief complaint on growth on the left side of the lower jaw around the last tooth since 6 months. Patient was apparently all right 6 months back. Then he noticed an ulcer in the left side of the lower jaw adjacent to the premolar and the molar area, which was initially small in size of approximately 1 centimeter and increases gradually up to a present size over the period of 6 months. It is associated with the difficulty in mouth opening since 1 month and increased sensitivity to spicy food and pain in that area. No history of bleeding or pus discharge from the lesion, no history of trauma or any history of dental intervention, no history of the swelling in the neck, no history of constitutional symptoms, no history of symptoms suggestive of the distance mates, no history of the high risk behavior, no history of exposure to the radiation, no history of the any ENT related complaints. Patient is non-diabetic and non-hypertensive. No history of the COX or any major surgery in the past. In the personal history, patient consumes the mixed diet with normal bowel bladder habits and normal sleep pattern. Patient is a chronic gutka chewer since 25 years and occasional history of the alcohol consumption also. In the family history, there is no history of the head and neck malignancy in the first degree relative. General examination done in well light room after informed.
Ankur,
Yes, sir.
Ankur,
Let's go to the local examination.
Okay, sir.
Ankur, before you go to the examination findings, I just want to tell you and tell everybody else also that in the history, you don't give the description of the size and the anatomical location that you as a doctor can do. The patient is not going to tell you that I had the lesion starting at the premolar and molar level. He will tell you at the most on the lower jaw it started.
Yes, sir.
So try and resist that temptation. Those are your findings in examination,
Yes, sir.
clinical examination.
Yes.
That time you can say that there's a lesion that is at the epicenter is at the premolar and molar.
Yes, sir.
But in your history, the patient is not going to tell you that I had a lesion at the premolar and molar level. And very often there's a tendency to bring the findings into the history as related by the patient. So try and resist that temptation.
Yes.
All right, now local findings.
Okay. So the facial symmetry is distorted, sir. There is a ill-defined swelling on the left side of the face, as we found it started from the left paracommissural region, and it is about the 2 to 3 centimeter short of the angle of the mandible. The mouth opening is restricted. It's a 2-finger nicotine stent with SMF and the trismus present, sir. Clinically, T4 ulcer proliferative lesion over the left lower alveolus, which is extending to the left lower GB sulcus adjacent to the molar side, sir. And it is associated with the gross paramandibular spread. The tooths are shaky and lesion is deeply infiltrating into the cheek substances, sir, with involvement of the skin. And in the neck, there is no evidence of the clinically palpable lymphadenopathy. So, this is the CT images of the patients, which shows the growth in the lower alveolus near almost extending up to the skin, sir, and it shows the loss of fat planes with the masseter muscles. So in the coronal CT view, sir, shows the gross paramandibular spread with deep infiltration of the cheek substances up to the skin, and this axial images shows the erosion of the bone. So the diagnosis, sir, is a 55-year-old chronic gutka chewers with an ulcer proliferative region of left lower alveolus and left lower GBS, most likely malignancy of oral cavity with stage clinically T4N0MX, stage 4A disease, sir.
What is the biopsy?
Sir, biopsy is moderately differentiated squamous cell carcinoma.
Then what will you do now?
Sir, I would like to confirm my diagnosis by the biopsy of the, after the biopsy, I would like to stage the disease by the CT scan and the ultrasonography for neck lymphadenopathy. So in this case, the disease is found extending up to the skin, and there is a presence of the bone erosion and the loss of fat plane with the masseter muscle. So in this case, I will go for the left full thickness cheek composite resection and reconstruction with the anterolateral thigh flap.
Is it important about the duration of trismus? Is it short duration or long duration? Does it matter?
Sir, patient is complaining of the decreased mouth opening since 1 month, sir. Sir, yes, it is clinically relevant because if the patient history is suggestive of the recent aggravation of the trismus, then it indicates that the invasion of the masticator space, or it may be due to the local inflammation or irritations of the muscles of the mastication. So there may be these two probability for that. So
If you did not have a CT scan,
yes, sir.
if you were located in Timbuktu and you didn't have a CT scan, can you judge whether this bone is involved or not?
Yes, sir. Because the tooth are shaky.
Yes.
Yes, sir. So the bone is involved, sir.
Yes.
And there is a presence of the paramandibular disease. So it entails a segmental mandibular resection.
If I tell you that the lower edge of the bone is very good, will you do a marginal mandible for him? Show me that slide of yours.
So this CT images, sir.
The other one.
Sir, even if the lower edge of the bone is good, but with the paramandibular disease, sir, we may end up with the segmental resection, sir.
We most definitely will. Yes.
Because this is the gross paramandibular disease.
Yes. So sometimes here, of course, it is grossly invaded, so this question doesn't come. But one of the things that we must all remember is that there are times when the bone is not involved and we are sure about it. The teeth are firm, the CT scan shows that there is no bone erosion, but the lesion is just abutting the bone and there is paramandibular disease, but not involving the bone. In those cases also, the bone may need to be sacrificed, because if you do not, you will get a soft tissue recurrence. This soft tissue it may not be possible to clear the soft tissue adequately without removing a segment of the bone,
yes,
many times when the bone is not involved. So whenever the bone is not involved, every effort should be made to preserve the bone. But we have to remember that there will be times, and quite often, that the bone is not involved and yet it has to be resected, because without resecting the bone, very often I cannot clear the soft tissue around it. And the recurrence will be because of the soft tissue being very extensively involved. So here you will do a segmental mandibulectomy.
yes, sir.
Suppose he has a shave and you find a large amount of skin involved.
Yes, sir.
Would you still consider surgery?
Sir, if there is a extensive skin involvement up to the zygomatic process or up to the parotid or retroparotid area, then we won't consider for the direct surgery, sir.
Then what other treatment would you consider?
Sir, in that cases, we can initially go up for the NSCT, neoadjuvant chemotherapy, sir. And if the response to the NSCT is good, then later on the radical resection.
That is correct.
And how will you reconstruct this patient?
Sir, in this case, as the cheek substance and there is involvement of the skin, so you have to reconstruct with the anterolateral thigh flap, sir, or bipedal PMMC.
Let's show those clips.
So you do a bipedal PMMC or a bipedal anterolateral thigh flap.
Yes, sir.
Yeah?
Yes, sir.
And what will be the adjuvant treatment that you will give to this patient?
This patient as clinically is a T4A disease, so definitely will require the radiation therapy, sir. Post-operatively, you will require the radiation therapy.
Chemoradiation.
Yes, yes, sir. Stage 4A disease, chemoradiation, sir. Yes.
What about the bone reconstruction for this patient?
Sir, in this patient, as the skin involvement is there, sir, then it is better to do a soft tissue reconstruction, and the disease is also very infiltrative type, so it's not to it's wise, sir, not to go with the bone reconstruction, because the reconstruction of the bone segment with the free fibula simultaneously we don't get the soft tissue bulk for the soft tissue reconstruction, even if we reconstruct the bone segment with the fibula.
It's a debatable thing. If you heard Dr. Prabha Yadav a couple of weeks ago, I think she would still opt for bone reconstruction. Because you see that his mucosal loss is not too much. There is a certain degree of skin loss.
Yes, sir.
And Dr. Prabha Yadav was of the opinion, and his intraalveolar region is also okay.
Yes,
That's also good.
yes, sir.
The retromolar region is good.
Yes.
It's a lesion confined to the lower alveolus and extending to the soft tissue of the cheek and close to the skin.
Yes, sir.
So I wouldn't completely rule out fibular graft.
Sir,
The very important point is that on table you have to take smears from the cut end of the bone.
yes,
In
sir.
this case,
Yes, sir.
because it's a pure alveolus lesion.
Yes, sir.
So it's better to confirm that it's free. Clinically also it should be free, and also pathologically
Yes.
on table. Because sometimes these extend up to the midline and beyond also,
Yes.
which is not visible to the naked eye.
Did you get that? These patients who have tumors that have perineural disease
Yes, sir.
will get into the alveolar canal
Yes, sir.
and will spread along the alveolar canal. So when you do a segmental mandibulectomy, or even if you do a complete posterior segment resection, you should take